Hello and welcome to Covered, COVID Vaccine Equity Research Dialogues from the Leonard Davis Institute at the University of Pennsylvania. I'm Allison Buttenheim, an LDI Senior Fellow and Associate Professor at the School of Nursing, here with my colleague Harald Schmidt, Assistant Professor in the Department of Medical Ethics and Health Policy at the Perelman School of Medicine. Our covered guest today is Dr. Rebecca Weintraub. Rebecca is a physician and a vaccinator. She leads vaccine delivery at Ariadne Labs and is also faculty director of the Global Health Delivery Project at Harvard Medical School. An incredible expert, and we're really delighted to have her today. So we're at another interesting moment in the vaccine rollout. We're about a week into vaccines for all. We also marked the 200 millionth dose administered by the Biden administration in just 92 days, so short of their 100-day goal. Harold, where are we? What does vaccines for all mean?
So vaccines for all should mean vaccines for all, but I think that's precisely what we want to talk about, whether it means that, right? So one thing that we've seen is that since everybody has become eligible, better off people are actually being vaccinated at twice the rate than worse off people. And we see this on this chart here. And that's a trend that I think we try to combat all along, and one that is concerning. So definitely we still need action there. The whole equity story isn't over with vaccines for all. And another important aspect is that there are some states that really make good efforts to also reach particularly undocumented immigrant groups who are a lot more vulnerable typically, but for whom many of the arrangements to get vaccines can really get in the way. And Rebecca, maybe we start here with you. I mean, you are, as Allison just said, a vaccinator yourself. So how does that look like for you? To what extent is that really a barrier that we need to address?
Well, first, so many thanks for having me. And I've just been huge fans of both of your work. So it's really just an honor to be here in conversation. I'll just start as a vaccinator. I have seen, and this is a real barrier, asking to see your ID, checking your ID at the mass vaccination sites, at the pharmacy sites, pulling out a government ID gets people worried. Why are you asking for my ID? What are you going to do with my ID? In the midst of so much of a complex dynamic that our vulnerable patients and populations have faced. And just to remind us that even though 20 states say the ID is not required, it's still happening on a daily basis. I saw this yesterday where a new vaccinator comes, asks for the ID, and most folks are going to, in a sense, abide by that request because they want the vaccine. They've already come and scheduled the vaccine, they're ready to go, but you can see that concern. And as both Harold and I have noted, we've seen this as people are waiting in line even with the schedule ID, when unfortunately security or police come by just to check the crowd, and you see people drop out of the line. So this is a true barrier, the request for an identification for a free federal vaccine. And people confuse it with I'll receive a bill, for example, or you're tracking my information for immigration reasons. It confuddles this moment, which is supposed to be a beautiful moment of relief.
And so, this is another one of those areas, I think, where we see a lot of variation across states, where there shouldn't be one. I think one of the big lessons as we come out of this is, right, how helpful or not was it that we give so much discretion to states? And as you noted, right, so some states do expressly mandate that you should not require ID. North Carolina is one of them. We see their provisions here on this slide. And then we still see some counties within these states that do require ID. So how can we think about streamlining this and really getting our ducks in a row so that both public health and equity are served here?
Absolutely. And I mean, one of the first portals of this is actually the vaccinator themselves. We do not need to start the encounter asking for your identification. We can reinforce that with our teams that we're working with, that if someone chooses not to show an identification, or that doesn't need to be the first question, you welcome someone to the site, you're glad that they're here, they enter the space or the building or the mobile unit, for example, but that's not a requirement. And I think that needs to get reinforced. Number one, we're actually hiring new vaccinators as new sites open, so that retraining needs to occur. And that sensitivity of what that means if that's the first question you're asking in the midst of an encounter. And I think for clinicians, I've never had to ask identification for someone I'm taking care of in the hospital or someone who comes to an outpatient clinic. And we're, in a sense, expanding the vaccinator pool. We need to think through what is the conversation we're starting to begin with folks, and what are those open-ended questions we should be asking first. I think the second is the whole system now needs to get upgraded for convenience. And it's not only identification, but every element of its design needs to think about the user experience of vaccination, not just that the vaccine is safe and effective, but how are we helping you schedule as a family? How are we ensuring it's family-friendly hours? So before school, for example, after work, and in proximity to where you're traveling and en route. And so I think this integration of transportation routes and vaccine sites, for example, of notifying folks, this is where a walk-in appointment's available, registering as a family, and then that communication coming from local leaders is essential in this moment where convenience should kind of override other strategies to date.
Rebecca, you and Harold had a great op-ed about this, which we'll definitely throw up as a link. And I tweeted about it and got some pushback from a couple people saying, you know, of course we have to ask for ID. How else will we know who's been vaccinated? So what's the response to this question of like, we have to do surveillance, and that's a tricky word anyway, but has an important public health meaning. How do we do that if we're not asking for IDs?
That's a great question. First, I find the problem is when we've asked people for identification. Most folks want to be part of the system. They want to understand what VAMS is. They are sitting there for 15 minutes of observation time. So first, I would just say this is the design of when do we ask for your identification, not the first thing off the bat. The second, we need to understand there's a small group of people we're showing the identification. They will not come for the vaccine. We'll have lost them in this process. And none of our data is perfect. We kind of understand at a population level, we're trying to track side effects, for example, at-risk populations, and that we're talking about 11 million people in a population size of over 200 million people, that we have to make it as convenient for these folks who would prefer not to be identified.
That's a great conversation. Thanks for those insights, Rebecca. Let's move on to our second topic for today, which is another aspect of vaccines for all. So again, we're at an interesting moment in the US where our supply and demand teeter-totter is teetering towards maybe some weakening demand. Some places that we're vaccinating a lot are starting to sort of level off in the amount they're doing. And as we see a just horrendous outbreak and health system strain in India, Brazil continues to have a terrible outbreak. Turkey, much of sub-Saharan Africa hasn't seen any vaccination beyond maybe frontline. The question comes up of, should we be sharing the supplies we have? That's true for our EUA vaccines that are under emergency use authorization, and even for example, the AstraZeneca vaccine, which haven't even been approved for emergency use yet or authorized. Rebecca, you thought about this a lot of eyes on the global scene. How do we think about and make decisions around sharing what we have?
That is a great question, Alison. I have to think we have to dial back a bit. That the dynamics that we're seeing today began playing out really in March and April of 2020, where certain nations said, I'm going to start procuring the vaccines and the doses that I want to secure for multiple platforms to create a portfolio for my country. And the term that we began speaking about vaccine nationalism, was that this was not an evidence-based distribution, but it was politics first, that the United States, Operation Warp Speed, the UK, were procuring doses to cover their population, and they actually procured beyond their population, as we know. The difference here was that this was not a pooled investment, and we're really a year into COVAX that's continually underfunded and underinvested in, even though there's donation of doses, for example, there's donation of investment, but they're really only about 30% of the investment capacity that they would need to provide 20% of the doses to the 92 countries within the COVAX facility. So to peel back, in many ways, these tiffs of vaccine nationalism began very early in 2020 that set us up for these unfortunate dynamics that we're having between the EU and the UK, for example, and now obviously setting India up for a moment where they don't have some of the raw materials they need for the Serum Institute of India.
And that's based on some export embargoes in the US, correct, in part?
Well, the first dynamic is the fact that an individual pharma company, so that management team, was setting the price and dosage for a nation. So if we think of how Israel was able to set up the dosage that they would like to receive from Pfizer and the data that they shared with Pfizer. So first, it's just that dynamic, that this was not a pooled investment in COVID-19 vaccines. And then the second, you're absolutely right. So then the question becomes, where are the raw materials needed to produce a vaccine? Where are the filters, the paper, the bags, and beyond even the vials and the syringes, et cetera? And so all those materials ended up being bilateral agreements between a country and the company versus using Gavi and some of the pooled mechanisms we have for financing.
You also thought a little bit about the distribution formulas, right? So what we're seeing is the market play out in a way that is not compatible with public good, which vaccines should be. We also see very disparate impact across countries. In the US, we've seen this really unique recognition of recognizing disadvantage in vaccine allocations to states. And we don't see that really at the global level. So, when I think of this, ideally, we would have a similar approach that we consider the shortfalls in life expectancy, the impact and the need in sizing the allocations, yet that is not what we're seeing. What's your sense to, what's the scope there now that we can still course correct that to compensate for some of those shortfalls, for initially just saying, well, let's leave it to the invisible hand of the market because that works so well. Well, we now know it has not worked well, but there is still scope to make adjustments. So this week, we've just had the announcement that the US will be sharing some vaccines, but what other possibilities do you see to course correct?
That's a great question. And acknowledging the dynamics that are set up in March and April were not only market dynamics, but it was nationalism at its worst. And now, obviously, with the resumption and the funding of the World Health Organization, the commitment of the Biden administration, the Biden-Harris administration to COVAX, we actually do think there's an opportunity at the G20 to not only ensure that COVAX is well facilitated, but actually we expedite this commitment to vaccine 20% of the 92 eligible countries. Most have received thousands of doses, less than 1% of the doses they need to cover these essential populations. Most countries in the world are facing intense scarcity of supply. So the fundamental investment right now needs to be an increasing supply of the vaccine. We need billions of doses of the vaccine portfolio, which means a massive orchestration of where's the manufacturing capacity and how do we flow that capacity so we can reduce the supply to even get to that 20% of doses.
I think one interesting policy question that has come up is, should our response, either our contribution of supplies to COVAX or sort of the raw materials, be dependent on our own demand in the US? And I've seen some calls, again, mostly on Twitter, for, hey, give US another 2 weeks to get the vaccine. And if you haven't gotten it, then that's it. Everything else starts going overseas. Obviously a big simplification. But do you think our contribution to the global problem should be responsive to demand here?
That's a great question. First, we know that we have sufficient raw materials and the manufacturing capacity within the United States to ensure there is a vaccine dose and doses for every American who wants a vaccine. So we are not facing a scarcity nor materials. That's already been reserved, in a sense, for the American public. We need to reinforce that message that every American that wants a vaccine, it's available. What we now need to explain is that we have the technical know-how and we have some of the raw materials, 36 of them, for example, that the Serum Institute of India needs. And then they can produce vaccines for their population, as well as many African countries. So the analogy that we made in a recent piece in the New England Journal was this is like PEPFAR, moving to PEPVAR for vaccine access. That this is truly the technical know-how we have in this country. And that is actually one of the legacies of Operation Warp Speed, that we, in a sense, use the federal government, an all-government approach, to ensure that we could quickly get the mRNA vaccines produced for the clinical trials, get the clinical trials up and running, so that we could have the evidence to get approval. And I think that is where we'll have a scaled impact. And it's honestly, I think, a leadership moment for this administration.
Great. Well, we'll be looking to the G20 to see what happens there, and hopefully some more order and some more generosity and global vision for this rollout. I'm Alison Buttenheim here with Harald Schmidt and our guest today, Dr. Rebecca Weintraub. This is Covered, COVID Vaccine Equity Research Dialogues from the Leonard Davis Institute of Health Economics at the University of Pennsylvania. Thanks for joining us, and come back again next time.